Welcome to our Skeleton Key Group Light 'em Up conference, where we get together to discuss exciting cases of electrolyte disorders in a fun morning report style.
Skeleton Key Group is a group of 40-odd nephrology fellows and residents who work together to build a monthly educational package with blog posts, tutorials, and visual abstracts for the Renal Fellow Network.
This conference is for educational entertainment purposes only. Topics discussed on this conference should not be used as a medical advice.
Let's light them up.
So hello and welcome to the Skeleton Key Group's Light 'em Up, our first podcast series. It's an initiative aimed at learning about how to approach and dissect our cases that we present at Skeleton Key Group in a fun and educational morning report style. My name is Sai Achi. I'm an internal medicine resident at Harlem Hospital. Excited to learn about the electrolyte world we have here today.
Well, great. Hi, everyone. My name is Saina. I'm currently faculty at Loma Linda University. Welcome to our first Skeleton Key Group morning report. Skeleton Key Group is a group of 50 plus fellows from across the globe. Daniel?
Hello, everyone. Thank you for joining us here today. I'm Daniel. I'm a nephrologist here at Overlook Medical Center in New Jersey. We're excited for this first video conference.
I'm Jamie. I'm a renal registrar in Newcastle in UK. Thanks for having me to present my case. And Joel?
And I'm Joel Tuff. I'm one of the senior faculty advisors for the Skeleton Key Group, and excited to be here.
Great. Well, let's get started. So our case today is a 29-year-old man who comes in with fatigue. I mean, who's not fatigued at the moment, but he's also got polydipsia and polyuria. In fact, he thinks that he's got diabetes, but he's on closer questioning, he's also constipated, very constipated, and this is new. It's interesting because he has a history of recurrent kidney stones and his brother has a history of recurrent kidney stones. But you look at him, he's a very well fit young man. His heart rate's 88 and he says it's normally around 50, but his vital signs are very reassuring.
Did they ever identify the nature of the kidney stone? Do we know what type of stone it was?
No, we don't. He's very vague. Outside hospital, we don't know what type. So this is the skeleton key. So of course we're going to light him up. So he is being lit up. We got our panel back, lovely key, and first ever set of blood tests, and we notice his creatinine is 1.4. So in UK money, that's 124 micromoles per liter. So abnormally high. And the other thing that's going to jump out of all these numbers is his calcium, normal range being 8.5 to 10.5. His is high, his is 12.2. So again, UK money, that's just over 3. So abnormal, definitely we're going to get excited about that. And he's at the bedside.
Daniel, when you look at this, go back to the skeleton key, but let's take a moment just to look at the chemistry. So you see the hypercalcemia. Daniel, where do your eyes go next?
Albumin.
And what's this albumin? We got no albumin. And why do you go there?
You want to check for calcium is mostly albumin bound. So you want to correct the calcium concentration in patients with hypoalbuminemia.
Yeah, but I mean, is that going to get you out? I mean, that's helpful when they're hypocalcemic. But I mean, have you ever seen somebody who's got like an albumin of like how high would his albumin have to be for this to be normal, right?
Right.
I just don't think the albumin is going to get you out of this box.
Next step is PTH.
Well, but even before the PTH, my eyes immediately go to that phosphorus, right? Because if it's primary hyperparathyroidism, you're going to get hypophosphatemia. So already I'm like, hey, that's kind of interesting because the number one cause of an outpatient hypercalcemia is going to be primary hyperpara. What do you think about that normal phosphorus?
As you said, with normal phosphorus, we're thinking maybe this PTH is to be in the normal range, probably.
Yeah, probably. What kind of things are going to drive that high calcium with a normal phosphorus? Where does your mind go there? Saina, what are you thinking there?
Yeah, that's an interesting question.
Right. So, okay. So normal phosphorus. So another one where you'll get a low phosphorus and a high calcium is going to be kind of modern milk alkali syndrome. So in milk alkali syndrome, excuse me, let me rephrase that. In classic milk alkali syndrome, where they took the SIPI solutions, which is sodium bicarbonate plus milk, they would get the high calcium and a high phosphorus because of the high phosphorus loaded milk. But in modern milk alkali syndrome, they tend to get it from calcium carbonate. It provides both the alkali and the calcium. And of course, it also acts as a phosphorus binder. So modern milk alkali syndromes, usually women trying to prevent osteoporosis or treating osteopenia or what have you, they'll get the high calcium, the high bicarb, and they'll have a low phosphorus from the phos binding action of that calcium carbonate. Here, our bicarb is maybe a little bit low, but mostly normal. Doesn't look like a milk alkali syndrome. And then the other things that will drive up the phosphorus, so the phosphorus is not abnormally low, but will have it would be a vitamin D stuff, elevated vitamin D, whether it's exogenous vitamin D or increased endogenous conversion from 25 to 125, will have enhanced phosphorus absorption. And so they'll have, tend to have high normal or frankly elevated phosphorus. Anything else remarkable on these chemistries panels? For a 29-year-old previously healthy, somewhat athletic guy.
Creatinine of 1.4.
Yeah, clearly some kidney failure, and that walks along with your hypercalcemia. How did hypercalcemia cause kidney failure? What kind of mechanisms do we have there? We got a number of mechanisms. What do you got to on them?
So vasoconstriction that can lead to direct vasoconstriction that leads to decreased GFR.
Yeah, and then they also get volume depleted. There's a couple different mechanisms for volume depletion there, right? So one, they'll shut down the thick ascending limb of the loop of Henle. You get activation of the calcium sensing receptor, which antagonizes your ROMK, so you stop getting potassium recycling, and so you'll get a kind of a furosemide-like effect there. And then that's going to be causing this polyuria and polydipsia, which is part of his symptoms.
DI type picture.
Yeah, his sodium is actually pretty normal here, not even trending towards the upper limit of normal. So he's doing a good job drinking. I'm not sure if I see anything else. Anything else remarkable that anybody sees? Okay, Jamie, please. That ultrasound was tasty. What do you got on the next slide?
So for people listening, what we're seeing is a POCUS image of a kidney, and there's medullary nephrocalcinosis bilaterally. You can just see in the medullary region that it's full of extra white stuff, and that's the calcium rebounding off the ultrasound. No hydronephrosis to explain the renal impairment. So I'll pass over to Sai.
All right. So just wanted to get a little bit more background on the patient before we kind of move on to how I'd kind of approach the case initially. If there's any other medical history for the patient aside from his history of kidney stones in the past?
No, he's completely fit. Young chap, no past medical or past surgical history.
Okay. Was there any history of malignancy?
No.
Just if he takes any other medications that could have induced this hypercalcemia?
He doesn't take anything at all. We quizzed him quite a lot about over-the-counter stuff, obviously, but nothing.
Okay. And any travel history or any going to any endemic areas or anything like that?
So he's been on a very posh cruise ship for the last 3 months. He's been working in the Caribbean. Whatever exposures kind of are associated with that.
Any exposure to occupational hazards or any chemicals?
No, nothing in particular, no.
And I guess lastly would be smoking history?
Never.
So given this history at this point, I think kind of, again, like we mentioned, we have the hypercalcemia. We were trying to rule out to see if there's any causes of the hypercalcemia through his medications or through any exposures via, say, a malignancy or TB or anything like that. I think the first thing that I would do would be to repeat the calcium just to make sure that it is in fact 12.2, and just to make sure that our labs are accurate. Then the next thing I'd probably want to do is, if the calcium in fact is high, what I'd want to do is I'd order a PTH, because again, when we're thinking of hypercalcemia, first things that jump to me would be, are we dealing with a hyperparathyroidism type of mechanism? So I'd get a PTH as well, and some urine studies, a UA and urine electrolytes as well, just to see about the creatinine, the calcium in the urine, and kind of go from there as a rough picture. I'd also like to get some vitamin D levels as well, 25 and 125 as well, just to make sure it's not any type of vitamin D excess or any type of vitamin D mechanisms as well. That's kind of what I'd start off doing for now and then kind of go from there. So once I kind of have these studies, I think then depending on the level, I'll have my nephrology colleagues come on board and help me out, kind of figure out and piece through what's going on with the hypercalcemia and what we can do for further management. So I'd like to call on my nephro colleagues and kind of present the case and see how they would approach this.
I mean, that's an interesting approach, Sai, and I really like how you approach to this case. I'm not sure about repeating calcium. What do you think, Joel? Like, would you repeat calcium in this case? Because patient has AKI, calcium is 12.2, and I kind of believe this kind of calcium in this guy. And based on his renal ultrasound, he has kidney stones. So I feel like the hypercalcemia is real here. We can repeat it, but I don't see the urge to repeat it, right? Because I kind of believe the hypercalcemia.
Yeah, I think we would be doing him a disservice if the calcium kind of started to normalize and we said, get lost, everything's fine here. Ignore your family history of kidney stones. Ignore the calcinosis on the ultrasound. Yeah, I think, Sam, I think you're right. I think that we've got real disease here, but I would be getting daily calciums regardless. I would start the workup. I don't think I would hesitate to continue to monitor that calcium.
Yeah.
Just to make sure we didn't need to do any more specific interventions just to lower the calcium.
Right, that's true. And then I agree with ordering PTH and vitamin D levels. I know that Jamie said that he's not taking any medications right now, right? So hopefully he's not taking over-the-counter vitamin Ds as well. Yeah, sometimes patients say that they're not taking anything, and then you check labs and they say like, oh, I forgot. I actually taking Tylenol, ibuprofen, and vitamin D every day, 3 times a day. So I hope he's not one of those patients. And urine electrolytes make sense as well, because I know that how Sai is thinking about it, because she wants to see that if the urine calcium is on the higher side or not. So do we have these labs right now?
Yeah.
Wow, nice algorithm. So basically, I feel like this is Sai's thought process, right, Sai? So she's asking to measure the PTH, and based on that, she's going to approach. And already she's asking for urine lights as well, especially urine calcium. Okay, sounds good. And she's asking for vitamin D. Let's see what your labs show. Okay, so I see that your 25 vitamin D is 72. 125 is 82, so it's high, and PTH is low, so basically it's not primary hyperpara. And ionized calcium, let me see what else. Everything else sounds normal, right?
So the 24-hour urine calcium is sky high.
Yeah, and 24. Yeah, basically the patient has hypercalcemia and dropping the
Hypercalciuria. Yep.
Yeah, hypercalciuria. I'm not surprised about that. So that's good. Okay, anything, and I see that the chest x-ray is clear. I see that you checked ANCA. What was the reason to check ANCA in this patient on first set of labs?
I think looking at these labs, it's reasonable to say that we threw the kitchen sink at it, and they probably weren't all done simultaneously. The vitamin A and the ANCA, whatever else. But I suppose with ANCA, thinking about granulomatomatous conditions and hypercalcemia due to that.
Yeah, I see. Okay, sounds good. I feel like ANCA is really expensive here to check, so I don't know how it's in UK, but and I see that you checked ACE activity. I know that our pulmonary crit colleagues are not going to love this because they're not checking ACE activity for sarcoidosis. I feel like you were thinking about sarcoidosis, right?
That was the thinking. I mean, you could argue with no symptoms and a clear chest x-ray and a clear CT chest that it's not a very high yield test.
Right. Sounds good. Okay. You know what? I'm thinking that, how about lymphoma? I'm like thinking about like more kind of uncommon diagnosis here. And since 125 is on the higher side as well, what do you think about lymphoma? It's one of my differentials at this point.
Yeah, no, I think that's a good thought. I mean, looking at that Reagan algorithm on the last slide, you have lymphoma, you have solid organ malignancy, you have osteolytic mets as all causes of hypercalcemia. So we were sticking the patient through the donut of truth, the CT chest abdo-pelvis pretty quick, because we can get a result from a CT faster than the 125 OH vitamin D by a long way. But that was clear. It didn't show any lymphoma, so that was very reassuring.
Okay, I see. And there is no like fungal infection. I know that this is so like uncommon to have like this much of hypercalcemia with fungal infection, but it can happen. I'm just searching for zebras here, but did you guys check for that?
Yeah, I mean, his imaging's clear. He has no symptoms. He's not immunosuppressed as far as we know. We do a test here called beta D glucan. Is that one you have?
Yep.
You know, it would be positive if it was pneumocystis or invasive candidiasis or something like that. So it's not shown here, but I think he had that and it was normal too.
Okay, and I see that you checked quantiferum for TB as well, which was negative. Daniel, what do you think? My colleague, nephrologist.
Right. So based on all these tests, I guess the ones that jump out, as you said, with the 125 vitamin D of 82, that basically thinking, is it generated more or is there some problem with its clearance, right? That's the thinking right now. And other stuff that you already mentioned with, you know, lymphoma, TB, sarcoid, seems like those are all clear. And, you know, and I guess with his family history being positive for his brother with similar issues in the past. So some sort of genetic issues is something that we should consider.
Yeah, I think it makes sense. Yeah, since he has the family history. But how do you test for genetic testing? Like, did you have any suspicions about this patient having some genetic causes? And how does that work? You send for genetic testing? Because sending this test for every patient, if we are thinking about it, it's going to be really expensive. And here I know that it's going to be difficult to test for like these things, and sometimes it's really expensive.
So we were very lucky in the UK. We had the 100,000 Genomes Project. So we, for a while, had a lot of access to genetic sequencing for patients with suspected or proven genetic conditions.
Yeah, I see. What do you think, Joel? Do you think that we should do like genetic testing in this case? Anything else that we should do before that? Because
No, I think I think this is a case where you have turned over every stone. I can't think of anything that you guys are missing. What you have here is I mean, this is hypercalcemia and hypercalciuria being driven by elevated 125 vitamin D. And you have gone through all the conventional, I mean, short of a bone marrow biopsy to try to pick up a lymphoma that's not showing any splenomegaly or lymph node signs on a CT scan. I'm not sure what else you have left to do besides genetics. I'd be interested if anybody has any other thoughts, but it feels like every stone's been turned over except for that genetic analysis.
Yeah, Jamie, give us the answer. I really want to know.
We're just showing our differential. We've got some potential genetic diagnoses on there. And here's the answer. So CYP24A1 mutations. So I'll let you talk us through it.
All right. CYP24A1 mutations. Again, this is a very rare and uncommon finding, but because of his family history and all the comprehensive workup that you guys did, only pertinent positive was the 125 vitamin D and the family history, which is why this was obtained. So CYP24A1 is a gene that essentially codes for 24-hydroxylase enzyme, also known as CYP24A1 enzyme, that breaks down active form of vitamin D, which is 125 vitamin D. It adds another hydroxylase, making it 124-25 vitamin D, which is an inactive form. But in this particular mutation with CYP24A1, you don't have the 24-hydroxylase, which leads to increased accumulation of 125 vitamin D form, which then causes hypercalcemia, acting on the GI system, bones, and leading to increased circulation of calcium. So often, as we said, you'll have patients, with the patients with the family history of hypercalciuria, you'll have renal stones, nephrocalcinosis, as we saw in our patient. And typically this presents in infancy where, patients would sometimes have exacerbated hypercalcemia from some sort of vitamin D drops, but it can also present in adults. So the management for this condition essentially is conventional stone prevention management with increased water intake. And with hypercalciuria, one of the things you want to do is you want to decrease your salt intake, sodium chloride intake, because salt, high sodium in the urine can lead to increased calcium in the urine as well. You want to avoid vitamin D products, and you want to avoid sunlight exposure. You want to monitor the mineral density, and consideration of something called fluconazole, which can inhibit 1-alpha hydroxylase to lower calcium, can be done. Although, again, because this is such a rare genetic disease, we don't really have great data on it, and long-term safety is unknown.
Any studies on using steroids, which is usually a pretty good way to reverse elevated 125 levels?
I didn't see that in the genetic disease here.
I mean, among your clinic patients with this condition, what do you have, 5 or 6 of them, I take it?
I have 0.
I mean, my take on steroids is that, they're very good sarcoids because they get into the alveolar macrophages and decrease the alpha hydroxylase there.
But if it's not lymphocytes that are driving it, it's not going to work.
Yeah, I think so.
I suspect you're right. Yep. That's super interesting. I guess the one thing that you would not want to do that you would typically run with somebody with hypercalciuria is you would throw them on a thiazide. But since this guy's already suffering from pretty significant side effects from hypercalcemia, it seems like a bad move here. I'm surprised, though, a little bit that he had the polyuria, the polydipsia, and the constipation with a calcium. What was it, 12? It seems so mild. A lot of these patients get by without any symptoms at that level. It's interesting that he was so symptomatic.
Yeah, that's interesting. And you told me that his brother had the same symptoms, right, Jamie?
Yeah.
Is it autosomal dominant? Is that
he's got biallelic mutations.
So it's a recessive gene.
Yeah.
Huh. Unlucky family. Interesting.
Well, interesting. Thank you so much, Jamie. Joel, do you have any take-home points for us?
There's one other genetic abnormality, right? It's the SLC34A1, which is also a recessive gene. This one codes for sodium phosphate transport in the proximal tubule, and these patients have tremendous increase in phosphaturia because they cannot reabsorb. Because they lose this sodium phosphate cotransporter. So they lose a lot of phosphate. It causes upregulation. Do I have this right? It causes downregulation of FGF23, which releases increased activation of 125 from 25-OHD. And so they also have elevated 125, though I don't think they're going to have a normal phosphorus. I would expect them to be hypophosphatemic, so it wouldn't quite be a match for this patient. And I think the other thing that's interesting is that, we were barking up the 125 tree right from the beginning when we saw that elevated calcium with that normal or upper limit of normal phosphorus. And I think that's an important clue to be considering, that's going to make it unlikely that it's going to be PTH driven. Okay. Good case. Really, totally an interesting case. Big take home notes are, Sai did a wonderful job kind of outlining your approach to these patients. You want to divide these patients up based on the PTH. That's going to be your primary branch point. You're going to have the high PTH and the low PTH. And the most common cause of hypercalcemia among hospitalized patients is going to be malignancy. In your outpatients, it'll be primary hyperpara. They're going to be on the high PTH level. People with suppressed PTH, that's going to be your PTHRP or your active 125 or just excessive calcium and vitamin D intake. Yeah, good case. Interesting stuff.
Perfect. Thank you so much, Jamie. So how do you want to end our report today? I feel like we have to say light them up one more time.
Oh, light them up. Yeah.
Light them up.
Light them up.
Yeah. Light them up.